Hi, my name's Louise Murray. I'm one of the clinical oncology consultants in Leeds, and my job today is to give you a brief introduction to radiotherapy. The aim of the session is to provide an overview of the fundamental principles behind radiotherapy and its delivery. And I hope that by the end of the session, you can firstly explain the basic mechanism of radiotherapy and its indications for use, describe the basic radiotherapy process, and lastly, understand some of the common expected side effects from radiotherapy. So how are we going to do that? Well, brief introduction, that's what we've just done. Then we're going to do a brief quiz. Then I'll move on to talk about the basic science of radiotherapy, the radiotherapy process, and lastly, some side effects. So first of all, you've either got a copy of the quiz or I'll read the questions out now. So it's basically true or false. This is just to assess what you know before I give you the rest of the talk. I'm hopeful that by the end of it, you'll get more of these right. So first of all, is it true or false? 40% of all patients cured of cancer will have received radiotherapy. True or false? In the UK, in 2011, approximately 1 million doses of radiotherapy were given. Is that true or is it false? Radiotherapy is given as an outpatient. True or false? Radiotherapy can be given as an emergency treatment. Is that true or false? Radiotherapy is available at most hospitals. Is that true or false? Radiotherapy is delivered accurately to within 2 millimeters of the target. Is that true or is it false? Radiotherapy is visible. True or false? Radiotherapy causes burns. Is that true or false? Radiotherapy can cause cancer. Is that true or is it false? And lastly, radiotherapy and chemotherapy can be given at the same time. Is that true or is it false? Don't worry, we're going to answer these questions as well as others as we go through the talk. So what is radiotherapy? So radiotherapy is the treatment of disease, mainly cancer, using ionizing radiation. Now, if you say to a patient, I'm going to give you radiotherapy, and they say to you, what's that, doctor? And you say, it's ionizing radiation, they'll start to look pale and quite unsettled. What I tell patients, and what you should tell patients, is radiotherapy is high energy X-ray treatment. All of our patients have had scans and X-rays before, and so that concept they can understand. So radiotherapy is high energy X-ray treatment. And the whole crux of radiotherapy, if you remember nothing else, is the aim is to get the optimal dose of radiotherapy to the tumour and the minimum amount of radiotherapy to the surrounding normal tissues, because it's when we treat the normal tissues that we run into problems with side effects. So as with most things in oncology, radiotherapy can be given with 4 different intents, and you may have come across some of these before. Sometimes we can do curative radiotherapy, otherwise known as radical radiotherapy, which, as the name suggests, is when we're trying to cure the patient, get rid of the cancer for the patient. And we've got common examples of that. Often when we're giving radiotherapy, we give it with curative intent. We give chemotherapy around about the same time. So common examples are head and neck cancer, and another common example is cervical cancer. We're giving the radiotherapy plus or minus chemotherapy with the aim of cure. In fact, radiotherapy is a very effective treatment for cancer. 40% of patients who are cured of their cancer will have had radiotherapy at least as a component of their treatment. So that's radical or curative radiotherapy. Adjuvant radiotherapy. Adjuvant radiotherapy follows a definitive procedure. So for example, patients might have surgery and then we give radiotherapy after that. A good example is a woman who has breast cancer and she has the lump removed or a wide local excision, and then we give radiotherapy to the rest of the breast just in case there are microscopic cells left behind. And we know that by adding radiotherapy on to having had surgery for breast cancer, effectively we achieve the same result as having a mastectomy, and the lady gets to keep her breast as well. So that's adjuvant radiotherapy following a definitive procedure. And then we do lots and lots of palliative radiotherapy as well. This is in patients in whom we've accepted we cannot cure the cancer and in whom they have symptoms related to the disease. So a common example might be a patient with prostate cancer that's spread to the bones or breast cancer that's spread to the bones, and the patient has symptoms, often pain, related to the spread. So supposing somebody had a bone metastasis in their leg from prostate cancer and it was causing them pain, we could give them some radiotherapy, and we've got about a 7 to 8 out of 10 chance of improving their pain after about 1 to 2 weeks, and that benefit can last for several months. So that's palliative radiotherapy, given with the aim of improving the patient's symptoms. And then sometimes we do neoadjuvant radiotherapy. That's prior to a definitive procedure. And quite a good example would be locally advanced rectal cancer. The patient has a rectal cancer, it's spread a little bit locally. If the surgeon went in and did an operation, there'd be a very high chance of leaving cells at the margin of where he cuts. We know that if we give 5 weeks of radiotherapy, along with some chemotherapy beforehand, we can shrink the cancer down a bit. And when the surgeon goes in a few weeks later, we increase the chances of him getting in and doing an operation and not leaving any cells behind, which we know increases our chance of controlling that cancer. So 4 different indications for radiotherapy. Radiotherapy is not available in all hospitals. It's given in what we call tertiary hospitals. So for those of you who are based in Leeds for your oncology placement, you will be in a hospital that has a radiotherapy department. Radiotherapy is an excellent treatment. One of the things that makes it very good is we can give it as an outpatient. Patients don't need to stay in hospital. The treatment only takes a few minutes, and so there's no value in patients being in hospital for 24 hours a day, several days a week for such a short treatment. So most treatment is given as an outpatient, and we generally do radiotherapy Monday to Friday with the weekends off. When patients have radiotherapy, they don't see it, they don't feel it, they don't hear it, and it only takes a few minutes to deliver. There are different types of radiotherapy, and there are 2 main types of radiotherapy that are used in the UK. The main one that we're going to think about is photon radiotherapy. That's the bulk of the radiotherapy that we deliver. And photons, as I've touched on, are high energy X-rays. And what they do is they penetrate deep into the body's tissue, but at the same time spare the overlying skin. And what happens is the photons produce secondary electrons, and it's those secondary electrons that damage DNA, single-strand breaks and double-strand breaks, and that's what can kill cancer cells. The important thing about radiotherapy is it can kill cancer cells and it can kill normal cells. The reason that radiotherapy works is that normal cells, up to a point, can repair radiotherapy-induced damage. Tumour cells often have defective DNA repair mechanisms, and that means that they can't repair radiation-induced damage. So when they come to divide, they realise that they're damaged and those cells can die. I'll touch on that again in a second. Another type of radiotherapy that we sometimes use are electrons, and those are electrons directly, and they damage DNA directly, and we can use electrons to deliver treatment to relatively superficial lesions. So maybe skin metastasis near the surface. We don't penetrate very deeply with electrons, and so it's only for superficial lesions. Skin metastasis is a good example. Both photons and electrons are delivered by a machine called a linear accelerator, and I'll show you an example of that in a second. And protons, you may have heard of those in the news. Protons are a relatively new treatment to the UK. They've been around for several decades. Protons are a different form of radiotherapy. They're particle radiotherapy, and we generally use them in very specific circumstances. Generally, we use protons for young people who've got brain tumours, children who've still got a growing brain, and we want to deliver a treatment that delivers a very low dose to the normal brain. And that's where protons have a potential role. If you think about a proton compared to a photon, if you think about Angry Birds on your iPhone, the red Angry Bird is like a photon. It comes along, hits the pig and keeps going. That's like a photon. We get this exit of the Angry Bird, or the exit of the photon. Protons are more like the black Angry Bird in that it travels into the tissue, you press the Angry Bird and it drops down and delivers all its dose in one place, and it doesn't travel on. That's a bit like a proton. There's no exit dose. And so if you're a 3-year-old or a 5-year-old who's still got a growing and developing brain, we want to deliver as little radiotherapy as possible to the normal tissue beyond the tumour. And so that's where we might use protons. But they are new to the UK, and they're not going to be a big focus of any exams that you're going to get. I only mention them because you may have heard of them already. As I've touched on, how does radiotherapy work? It's we get what we call a differential cell kill. So normal cells have got effective DNA repair mechanisms, and so up to a point, they can repair the damage that radiotherapy causes. Cancer cells normally have defective DNA repair mechanisms, and so when they get damaged by radiotherapy, when they next come to divide, they realise that they're damaged and they can undergo cell death. Sometimes that's apoptosis, sometimes it's what we call a mitotic catastrophe, mitotic cell death. But regardless, we get this differential cell kill. Normal cells can repair themselves up to a point. Tumour cells generally can't repair radiotherapy-induced damage. However, if you give enough radiotherapy to a normal cell, eventually you will damage it to the point that it can't repair itself, and that's when we get into trouble with late side effects, which we'll come to. But also that's when we can run into trouble with second cancers. Radiotherapy, as well as being used to treat cancers, can cause second cancers. The risk is low, but we know that it's real, and that's why there are very strict radiation protection laws governing where radiotherapy can be delivered, who can deliver radiotherapy, and how much exposure different patient groups and professional groups can have to radiotherapy. When we talk about radiotherapy doses, we talk about the dose in grey. So radiotherapy dose is grey, G-R-A-Y. Radiotherapy is often given in a series of small doses, and we call each individual radiotherapy treatment a fraction. So we might give a dose of, say, 50 gray in 25 fractions. That's 25 usually daily treatments. Because we deliver treatment in lots of little fractions, we deliver a lot of fractions per patient. In fact, we deliver about 2 million fractions of radiotherapy per year in the UK. So each fraction, when we're trying to cure a tumour, often, not exclusively, but often each fraction is around about 2 gray. And 2 gray is just about enough radiotherapy to kill some cancer cells, but is less likely to cause long-term normal tissue damage. And that's why when we're doing radical treatments, it's often a lot of small, approximately 2 gray per fraction treatments. So for example, for some head and neck cancers, we might give a dose of 70 gray in 35 fractions. So that's 2 gray per fraction. And remember, we treat Monday to Friday once a day, weekends off, and so 70 gray in 35 fractions takes about 7 weeks to deliver. Palliative radiotherapy, for patients who've got incurable cancer, we're just wanting to control symptoms. We want patients to have relatively straightforward treatments with minimal hospital visits. We tend to do larger doses per fraction. And part of the reason for that is we're less worried about late side effects in that patient group. And so for palliative treatments, we might give 8 gray in a single fraction, or we might give 20 gray in 5 fractions, or 30 gray in 10 fractions. So a bigger dose per fraction, short course of treatment. In fact, for 8 gray single fractions, patients can come to the department, have their treatment designed, have their treatment all in one visit, and it's done. So we have a whole radiotherapy process that I'm going to talk through. This is just a kind of overview of the process. We've got the pre-treatment phases, the treatment planning phases, and then the treatment itself. And we'll focus on various aspects of that pathway. The things we're going to focus on most of all, or immediately, are the consent process, immobilization, CT simulation, tattoo, volume definition, treatment itself, and then follow-up during treatment. So let's go to the beginning of that process. So the consent form, all patients will sign a consent form for radiotherapy. A lot of what we do is about communication. Tell the patient why we're going to do it, tell them what the benefits are, what the intended benefit is, tell them what the alternatives are, and tell them what the side effects of treatment are. We've got standard forms that we use that we individualise to the treatment and the patient that we're dealing with. So always consent your patient, tell them what you're going to do and why you're going to do it. The next step in the process is immobilisation. If somebody has a tumour, let's say on their cheek, I want to make sure that every time I turn the radiotherapy on, maybe for 35 treatments, I want to be confident I'm definitely going to treat the cheek. If I go too high, I will miss the tumour and I'll put some radiotherapy through the eye. That could make the person blind, that could give them a cataract. Equally, every time I turn it on, I want to hit the cheek. I don't accidentally want to miss the tumour or go too low, and then I'd cause a sore reaction in the mouth. So we need to hit the right spot every time. That's the crux of radiotherapy. And if patients have a brain tumour or a head and neck tumour, one of the ways to help us ensure that we always treat the right spot is to keep patients still. And so immobilisation is the area of radiotherapy where we make sure the patient is kept in the same position, so it's reproducible between designing the treatment and delivering the treatment. So head and neck cancer patients and brain tumour patients get a mask made like you can see here. This is a Perspex mask. Essentially the patient comes to the mould room. We use like plaster of Paris to create a mould of their face. We cover that in Perspex and get an individualised patient shell. And it is designed to hold you still. It's not tight, but it is snug because that's the point of the treatment. And you can see somebody wearing an example there. That's the patient wearing the mask. As I say, it's snug, but it's not tight. And then the other sort of masks that we use are what we call thermoplastic shells. These are like white sheets of plastic. They feel rigid. We put them in hot water, then they go all bendy. You can shape that over the patient's face, and then that sets hard. And again, we've got an individualised mould of that patient's head or their head and neck area. So we've got a couple of examples here. Adult patients, we just tend to use plain white patients. Our younger patients, we treat a lot of young patients with brain tumours, sadly. We individualise the mask to make it even more bearable. So we turn that young patient into a superhero. So I believe that's Darth Wall. We've got other sorts of immobilisation depending on which parts of the body we're treating. So this is for a patient where we're treating their torso and we've got them up with their arms above the head, and that blue mould just keeps things in the right place. This is called a vacuum bag. Patient lies in what's a bit like a blue bean bag. We suck the air out and effectively that sets hard, giving us a mould of the particular part of the body that we're interested in. So the first one that we can see, we're concentrating on the upper part of the body, and down below you've got a patient in a whole body mould that we're trying to keep still over their whole body. This is a CT simulator, so this is just like a normal CT scan with a few important differences. First of all, the bed is hard and flat. Everything's to do with keeping the patient in the correct position and the same position for treatment to treatment. And so this is a hard bed, so they can't sink down and change their position. And also there are marks along the side of the bed so that we can always line the patient up with reference to these marks. Otherwise, it's very like a normal CT scanner. So the patient has immobilisation as necessary, and they have a CT scan on which we design the radiotherapy. It's different to the diagnostic scans they have. This is a specific scan to design the patient's radiotherapy. While they come for their CT scan, they often have a tattoo. In fact, they often get 3 tattoos, one in the middle and one on either side. And that's to allow us to line the patient up on the couch in reference to these CT scans. We often use laser lights. You can just see the corner of a laser light on that slide. We use these laser lights to line up to their tattoos, and then we know we've got the right position on the outside. We can then do scans to check the position on the inside. So we give patients tattoos. They're absolutely tiny. You can see a picture of a dime with a tattoo next to it. So they are there forever. We can sometimes remove them, but they're there for a long time, but they're very, very small. So the first step, immobilisation, CT scan and tattoos. The next thing that involves the clinical oncologist or the doctor is designing where we want the treatment to go. And there are 3 key volumes when it comes to designing where we want the radiotherapy to go. First of all, we draw tumour that we can see. That's called the gross tumour volume, or the GTV. So that's tumour that we can see. Well, we obviously want to treat that. However, we all know that on a scan, tumours don't stop right at the edge of where we can see them. We know that there's liable to be microscopic spread, and so in most cases we don't just stop at the edge of the GTV, we put on a margin to take account of that microscopic spread, and that margin we call the clinical target volume. And then we also know that tumours can move about a little bit, and they're never in the same position from day to day, even though we've got good immobilisation. And so we need a bit of a margin to take account of potential variation in setup from day to day and in tumour motion. And we call that margin the planning target volume. And just about all tumours, and in fact all tumours need some sort of planning target volume because things can vary from day to day. Let's think of the prostate, for example. If somebody has a full bladder, the prostate might be a little bit lower down, and so we need a margin to take account of that. If somebody's passing gas through the rectum, the prostate might be pushed forward, and if we don't have a margin to take account of that, then we could miss the prostate for part of that patient's treatment. So we have to have this planning target volume as well. So the gross tumour volume, tumour that we can see, the clinical target volume, a margin for microscopic spread, and the planning target volume, a margin to take account of day-to-day variability and potential tumour motion. We can see an example of this here. This is a patient who's got a lung tumour on the left side. You can see we've drawn around the tumour that we can see in red. There's then a margin added in green to take account of microscopic spread, and then there's another margin in blue to take account of day-to-day variation. Also, patients breathe, and so you get more motion in a sup-inf direction than you do side to side. And so you can see on the coronal view that we have a larger margin sup and inf for our planning target volume than we do side to side. We draw the tumour that we want, the tissue that we want to treat, that's what we've just discussed, I also spend a lot of time drawing areas that I don't want too much radiotherapy to go to. So that's your normal tissue. So for example, in this patient with the lung cancer, we would draw the spinal cord. We can't give it too much radiotherapy or it will cause paralysis. We draw the heart. We don't want it to get too much radiotherapy or we could cause cardiovascular damage. We don't want the normal lung to get too much radiotherapy or we could cause fibrosis and therefore lots of breathlessness. So we draw where we want the radiotherapy to go and we draw where we don't want too much radiotherapy to go. After we've done that, our design on the patient's planning CT scan passes to physics, and they do lots of sums and calculations to work out how to get the optimal amount of radiotherapy to the tumour, but at the same time minimise the dose to all those normal tissues that we've drawn on the scan. Now, in the case of a palliative radiotherapy treatment, we just want something relatively simple with low toxicity that's easy for the patient to manage. And so this is an example of a patient who has a large pelvic bone metastasis. I've drawn around that in red. That's where we want to treat. There's a bit of a gap to take account of the fact that we have setup variability in a clinical target volume. And this is a very simple beam arrangement. We're putting one beam in from the front and one beam in from the back, and essentially that meets in the middle, which is where the tumour is. So that's a simple palliative treatment, beam from the front and a beam from the back. Nice and easy. Here's another example. This is a patient who's had a lumpectomy or a wide local excision for breast cancer, and now we want to deliver adjuvant radiotherapy to the remaining breast. And what we've got are two beams going across the breast. One is coming in from the left and one is coming in from the right. We call this a glancing pair. They glance across the chest wall, therefore encompassing all of the breast tissue, but minimising the dose to the lung underneath and to the underlying heart. We use this arrangement because if we just did one beam that came in from the front, we would cover the breast, but we'd get lots of exit dose through the normal lung and through the heart. With this way, you can see there's a small sliver of lung that will get radiotherapy, but it's only a small sliver, and a very small proportion of the heart might get some radiotherapy. Nowadays, we can treat these patients in breath hold, and that means that we fill their lungs before we turn the radiotherapy on, and that actually moves the heart back, or effectively fills the lungs with air to minimise the amount of radiotherapy received by the heart, because we know that long term that can put patients at risk of cardiovascular disease, and we obviously want to minimise that. And here's the machine that does the business. This is our radiotherapy linear accelerator. You can see it's got a black couch, the same as the one on the planning CT, and again it's got those marks on the side, so we can line the patient up in reference to the tattoos that they've got using the laser lights, so that we get the same position on the outside as we had when we did the planning CT scan. The radiotherapy comes out the round head of the linear accelerator, and that grey circle is essentially a gantry. So that head can move round in a circle, and so radiotherapy can be delivered from 360 degrees, and so we typically use multiple beams to angle around the patient so that they all centre in on the tumour, but again minimising the dose to the individual normal tissues. So as an example, here's a bit of a mock-up. The patient's on the bed, the radiotherapy linear accelerator moves round the patient. Radiotherapy is delivered from multiple different angles, thereby focusing in on the tumour in a roughly central point, so that maximum dose goes to the tumour and the dose elsewhere is spread out or minimised. Also, to try and protect the normal tissues and make sure the radiotherapy is going exactly where we want it, we shape each radiotherapy beam. And that's achieved by virtue of leaves of tungsten, shown on the right-hand picture, which are in the head of the machine. So that picture on the right is in the head of the treatment machine, and effectively these are like shutters effectively like shutters, and what they do is they can move in and out and create an aperture. So for example, if we were treating a perfectly circular aperture, we would position those leaves of tungsten so that they were in a circle. If we've got a square tumour, we would position them so the aperture was a square, etc. We can create any shape, and those are automatically moved to match to the shape of the target that we're trying to treat. Here's a mock-up of radiotherapy treatment delivery. Patients lying on the bed. This is a patient who's got two lung tumours being treated at the same time. On this occasion, the linear accelerator is on all the time, and the machine is moving around the patient in an arc. Radiotherapy is being delivered all the time, and the beam is constantly being shaped by those leaves of tungsten that sit in the head of the machine. You can see them moving down the bottom left corner. So all the time that beam, which is mocked up in the yellow, is constantly changing shape to ensure that we get the optimal dose to the tumour and the minimum dose elsewhere from each angle that we're delivering the radiotherapy. As I said, patients don't see it, don't hear it, don't feel it, and it only takes about 2 to 5 minutes to deliver a treatment. So that's how we do it. What about toxicity? Well, it depends on what part of the body we're treating, and acute toxicities are caused by transient damage to the normal cells that will repair. Usually takes a couple of weeks for the acute side effects to start, and then they settle down a couple of weeks, or begin to settle down a couple of weeks after the treatment's finished. Those are the local side effects. Fatigue is quite common, and a skin reaction can be common as well, depending on which bit of the body we're treating. When it comes to radiotherapy side effects, the way that I think about it is think in the short term, the tissue gets inflamed, you get an itis. In the longer term, the tissue can become fibrosed, and then you get fibrosis. So think osis. So short-term itis, long-term osis. And we'll talk through these as we go through it. Think about which bit of the body you're treating. Think about what normal tissues the radiotherapy passes through on its way into the tumour, and think about what normal tissues the radiotherapy passes through beyond the tumour, and then think short-term itis, long-term osis. So let's think about a head and neck cancer patient. Let's say somebody who's getting their tonsil treated. In the short term, they may well get a skin reaction. The skin becomes red and inflamed. That's radiation dermatitis, and that causes pain. We don't call it a burn. It's a radiotherapy skin reaction. Skin reactions can be very sore in radiotherapy. Just as the skin on the outside can get red and inflamed from radiotherapy, so can the mucous membranes on the inside, and that gives us a mucositis. When we give patients mucositis, the salivary glands don't work quite as normal, we don't produce as much watery saliva, and you get left with this thick, sticky, useless oral secretions, which are quite unpleasant for the patient. Unsurprisingly, if you've got thick, sticky oral secretions and your mouth's sore, your taste isn't normal either. Patients can get very fatigued with head and neck radiotherapy, and long term we can cause permanent fibrosis of some of the salivary tissues, and that means they don't work, and patients are left with a long-term dry mouth. So let's have an example of that. This is a patient who's maybe about 10 days into a course of radical radiotherapy, and the skin is ever so slightly red. You almost have to peer to convince yourself there's some redness there. So this is a very mild radiotherapy, radiation dermatitis. At the end of treatment, maybe in the final week of 7 weeks of treatment, the skin can look like this. We see it less actually with our modern art treatments, but we do see skin reactions like this. So this is right at the end of treatment. You can see the skin has peeled off the surface, it's denuded, it looks really red and angry. That will continue for 2 weeks after the treatment's finished, and then it will gradually begin to heal, and cosmetically will look essentially normal. The skin might be a slightly darker pigment longer term, just slightly deeper red, and if you felt that patient's neck years down the line, it would feel more firm, and that's because of fibrosis of some of the normal tissues in the skin, leaving the patient with less elasticity than they had before. But as a general, passing them in the street, you may well not notice any difference once that's had time to heal. As I said, just as it goes red and angry on the outside, it can also go red and angry on the inside. So this is a patient with mucositis. So all the linings on the inside of the mouth are red and sore and peeling, and you can understand why it's therefore difficult for these patients to enjoy food. In fact, a lot of patients can lose weight during head and neck radiotherapy, and to try and prevent that, these patients see a dietitian every week who could advise them on supplements. And if we're very concerned that they're losing a lot of weight, or if we know that they're going to lose a lot of weight during treatment, then we can pass an NG tube, or we can put in a PEG tube prophylactically to try and keep their weight up, as we know that that's better for patients. So how do we manage these side effects should they happen? So patients having head and neck radiotherapy need very good mouth care. So we give them MuGuard, we give them Gel Clear, which is like a clear gel that they can put on for some soothing. Mouthwashes, aspirin gargles, Mucane's got some anaesthetic and some lubricant in it to help with pain and to help patients swallow things over. And normal saline nebulizers are good for these thick secretions, helps patients get them up and get them clear. Lots and lots of emollients for skin care, and we've got special preparations should the skin break down. Analgesia, because this is very sore. Patients are often end up on opiates in the short term, and often towards the end of a radiotherapy course they can end up coming into hospital for a few days to have their nutrition looked at by our dietitians, but also in terms of optimising their analgesia, and sometimes patients need a syringe driver to deliver optimal opiate analgesia. Let's think about prostate cancer. So prostate at the other end of the body, you've got the bladder up above and you've got the rectum behind. And so if we treat the prostate, it in itself might become inflamed during treatment in the short term, so they get a prostatitis, and they can get inflammation of the bladder, which is a cystitis. And if you get cystitis, patients might find they've got burning when they pass water, frequency and urinary urgency as well. As I said, the back passage is immediately behind the prostate, and so the rectum can become inflamed, and with that patients can get some diarrhea. They can pass some mucus or slime from the back passage. They can even pass some blood from the back passage, just because the rectum has become very inflamed. If the prostate becomes inflamed, prostatitis, then it becomes hard to pass water and the urinary flow is reduced. And if we're treating a lot of bowel, patients might get some abdominal pain. Most of those things will settle down. Longer term, we can cause damage to the small blood vessels in the bladder and in the rectum, and that can give later bleeding. So patients can have hematuria, or they can have, we call it proctitis, but it's really a late side effect. We can cause telangiectasia in the bladder, causing hematuria, or telangiectasia in the back passage, which we call proctitis, which can cause bleeding in the future. If we treat a lot of bowel in the short term, patients can get nausea as well. So how do we manage these side effects? Well, in the first instance, if somebody's got urinary symptoms, we make sure they don't have a urinary infection, so we send a sample. Analgesia can help with pain. If people are having urinary symptoms, a good fluid intake keeps the urine nice and dilute. If the flow becomes poor, then tamsulosin relaxes the muscles in the middle of the prostate to improve urinary flow. And if people are having a lot of diarrhea, then fibrogel helps bulk out the stools and makes them more satisfying to pass. Last example, let's think about lung cancer. So let's think about a tumour in the lung, close and involving some lymph nodes as well. So we're treating the lung and the mediastinum. In the short term, the gullet or the esophagus will become red and inflamed, and that can cause esophagitis, and therefore it's sore to swallow, so dinophagia. And essentially that's mucositis in the esophagus. We can irritate the lungs, which can cause cough and shortness of breath. And then patients can also get chest pain, particularly with more peripheral tumours. When we're treating those and catching some of the pleural tissue, patients can get pain. If we're treating a low-down lung cancer and we catch some of the stomach or the bowel, patients can feel a bit sick. And then pneumonitis, inflammation of the lungs, that can happen about 6 to 8 weeks after radiotherapy. Patient becomes breathless, has a dry cough, and we use steroids and oxygen to treat that. That can be very serious if it involves a large amount of lung. How do we manage these side effects? Well, lung cancer patients, if they're breathless and are coughing, we need to make sure they don't have a chest infection, so we'll get an x-ray. Inhalers and nebulizers are also important, and remember, a significant proportion of these patients will have smoking-related damage as well, so they're often already on inhalers and nebulizers, and so we need to optimise those. Analgesics for pain, and Mucain is very good for esophagitis, so that's some lubrication and some analgesia, which helps patients swallow despite the fact they've got mucositis. For pneumonitis, as I've said, occasionally we need to use steroids to settle down that inflammation. Just to mention chemoradiotherapy, we touched on that before. That's when chemotherapy and radiation therapy are given around about the same time, often in the curative or neoadjuvant setting, to try and increase our chances of cure. It makes radiotherapy more effective, we know that, but it comes at the cost of increased toxicity. And one of the things that we didn't used to see often with radiotherapy, but can see much more with chemotherapy and must be aware of, is the risk of pneumonitis. Just to say, because it's in the quiz and I haven't mentioned it yet, when we turn the radiotherapy machine on, we want to be within 2 millimetres of our target to make sure that we're super accurate. So now we're going to go back to those questions that we looked at the beginning. So, 40% of patients cured of cancer will have received radiotherapy. Is that true or is it false? So that's in fact true. Radiotherapy is very important for the cure of cancers. It's also very important as a palliative treatment in improving symptoms in patients who've got incurable cancers as well. Question 2. In the UK, in 2011, approximately 1 million doses of radiotherapy were given. Is that true or is it false? So that's false. In the UK, usually we give about 2 million fractions per year. That's all those little treatments that are given that divide up the total dose. Question 3. Radiotherapy is given as an outpatient. Is that true or is it false? So radiotherapy is mainly given as an outpatient because it's quite quick to receive, and there's no benefit for patients staying in hospital for a prolonged length of time when they can come and go every day. Occasionally for emergency treatments, or when patients are too unwell to travel, we do keep them in hospital. Or sometimes if patients are coming from a long way away, we keep them in like hostel wards to save the journey every day. Question 4. Radiotherapy can be given as an emergency treatment. Is that true or is it false? So I didn't mention that specifically, but radiotherapy can be given as an emergency treatment, and sometimes we even do that at the weekend. So the most common example is spinal cord compression. I'm sorry, I didn't mention that before. Hopefully you've come across radiotherapy emergencies before now. Question 5, radiotherapy is available at most hospitals. Is that true or is it false? So that is false. Radiotherapy is only available in tertiary centres, which is why patients from peripheral hospitals like Huddersfield or Harrogate or York, they have to travel to Leeds in order to have radiotherapy. Question 6, radiotherapy is delivered accurately to within 2 millimetres of the target. Is that true or is it false? So that's true. As a minimum, we try to be within 2 millimetres of the target. We often try to be more accurate than that, and we achieve that by setting up patients appropriately using the tattoos and the laser lights, but also by doing CT scans before we turn the actual radiotherapy on, just to make sure that the position is as accurate as possible. And if it's not, we can shift the radiotherapy couch by millimetres just to get the patient in exactly the right position. Question 7, radiotherapy is visible. Is that true or is it false? So that's false. Radiotherapy is invisible. You don't see it, you don't feel it, and you don't hear it. Question 8, radiotherapy causes burns. Is that true or is it false? So that's false. Radiotherapy does cause a skin reaction. It's not the same as a burn. It's a radiation dermatitis. Question 9, radiotherapy can cause cancer. Is that true or is it false? So that is true, radiotherapy can cause cancer. The risk is low. It's when we damage DNA up to normal cell DNA up to the point that it can't repair, but then it can start to get mutations and develop a second cancer. That's very serious, and that's why we have such strict laws regarding how much radiotherapy different professional groups can receive. And lastly, radiotherapy and chemotherapy can be given at the same time. Is that true or is it false? So that's true. Radiotherapy and chemotherapy can be given around the same time. We can do it within an hour of each other. And we know that adding chemotherapy to radiotherapy increases the effect of the radiotherapy at the price of increased toxicity. So those are our questions. Final couple of slides. Last couple of things, we have a YouTube video that shows a patient going through the radiotherapy department. The voiceover is by Alan Bennett, a very famous Yorkshireman, so I encourage you to have a look at that. And secondly, we have a video showing an adult patient having a mask made for immobilization, which is what we use for the head and neck cancer patients or the brain tumour patients. So I encourage you to have a look at both of those. And lastly, if you're so inspired, there are lots of prizes available for people who are interested in radiotherapy, and those can be accessed on the Royal College of Radiotherapy website. So those are for you at your leisure. Any questions? Please feel free to get in touch. Jane Freer can provide my contact details. Thank you.